we aim to provide low-cost, high-quality healthcare services with dignity to the remote rural communities. One of the greater difficulties for us is not so much in changing antibiotic, but there is a huge demand for injectables in the settings where there may be borderline uh, patients who would ideally would require an inpatient care, but you need to treat in an outpatient basis because there is no other choice.
This is the CSA podcast, presented by Social Alpha, supported by Blockchain for Impact.
Hello, this is Dr. Rajani Surendar Bhat from the Community Science Alliance. The Community Science Alliance, or CSA, is a partnership of community health organizations, clinicians, and researchers advancing the science and practice of contextually relevant evidence-based medicine in resource-constrained settings. The CSA is an initiative of Social Alpha's health and wellness architecture, building on our focus with primary healthcare. And today we are in conversation with Dr. Pavitra Mohan, the co-founder and director of Basic Health Services, where we're going to have a conversation about a topic that we both care deeply about, which is community acquired pneumonia. Welcome to the CSA podcasts, Dr. Pavitra Mohan. It's wonderful to have you here with us today. And I would love to hear more about your work at BHS, and if you could share that with our listeners as well.
Thanks much, Rajani, for this introduction and for inviting to speak about and converse about community-acquired pneumonia. So at Basic Healthcare Services, we aim to provide low-cost, high-quality healthcare services with dignity to the remote rural communities through a network of clinics that we call as Amrit clinics. These are located in remote rural communities of South Rajasthan, where the population is marginalized. There is a lack of access to healthcare otherwise, and there are high levels of malnutrition and tuberculosis. So I just wanted to set the context so that when we are discussing, the context does become important.
Having visited BHS, I have seen the amazing work that your doctors and team does at the Amrit clinics. And that's one of the big reasons why we wanted to have you here with us to discuss this topic, community-acquired pneumonias. We know that pneumonias remain one of the leading causes of morbidity and mortality around the world. And this is especially true in resource-constrained settings, where it is much more challenging to get an accurate diagnosis and effective treatment sometimes when it's more severe. There are far more challenges that you face. And that's one of the things that we wanted to bring to our listeners, and as to how do we use the evidence available to do the best for our patients. It's not always, we know that pneumonia is an infection of the lungs. And we call it community-acquired pneumonia when it is acquired outside the hospital setting. But it has its own diagnostic challenges. It doesn't always present in the way that we read in textbooks. So can you share a little bit with our listeners about the challenges you face with diagnosis of a community-acquired pneumonia in your clinics?
So very often the patients would come with fever, recent onset of cough, difficulty in breathing, sometimes associated with chills. There are sometimes diarrhea that they, along with the cough and breathlessness that people present with. If they already have an existing chronic lung disease, then it becomes more challenging. Is it just worsening of the chronic lung disease, or is it an acute exacerbation of the chronic lung disease, or is it a superadded infection, pneumonia that's on top of the chronic lung disease? And there, I think the worsening of signs and symptoms clinically, increased production of sputum and fever provides, an indication that they may have a superadded pneumonia that they have acquired along with their underlying lung disease. So these would be typically the presenting symptoms that people at our clinics land up with. In our context, since tuberculosis is highly prevalent, we would also look at the duration of the symptoms, history of contact that they may have with a patient, another person with tuberculosis. And sometimes hemoptysis is a common presentation, which may sometimes overlap with tuberculosis, and sometimes it just might be a feature of community-acquired pneumonia. So these would be some of the common presenting features of adults that present to with pneumonia that is community acquired in our settings. Uh, on examination, I think examination is extremely critical in these situations, because we, as you know, that we do not have easy access to chest X-rays or lab tests. And one of the important things to then make a diagnosis is clinical, sound clinical examination. So looking at respiratory rate, for example, right? I mean, so is there tachypnea? Is the person, how is the orientation? Is there confusion? The blood pressure, is it, stable or is it unstable? That helps, as we discuss a bit later about the severity, helps in also determining the course of treatment. Auscultation to, both look at whether there is a potential consolidation underlying, um, or there is these that would suggest, a bronchoconstriction, which may be because of the underlying chronic lung disease. Percussion to also look at potential pleural effusion. These are things which you cannot otherwise pick up unless you do a sound clinical examination. So if there is on examination, if there are findings that are suggestive of a consolidation, or there are extensive crepitations, that would kind of help you, make a clearer diagnosis of the pneumonia, as well as some anatomical description of where that consolidation could be.
Pavitra, what you've mentioned is so very important because the context in which we both practice is so different. I'm a pulmonologist in a tertiary hospital, and I have access to radiology and microbiological tests that can help me in getting a more accurate diagnosis. But it never takes away from the fact that a sound clinical diagnosis can be made with paying attention to the history, to the physical examination and findings that we find. That being said, one is hopeful of improved access to radiology and lab testing. But you brought up some very important points in that history and physical examination. And it's something that even in a low resource setting, one can always pay a lot of attention to. You spoke about the orientation and confusion, if the patient has any, the respiratory rate, the hemodynamic instability, if they have a low blood pressure. Along with when COVID-19 came around, another important parameter came into our lives, which is that pulse oximetry and checking the oxygen saturation became more widely available. So that, along with looking at whether the patient has other risk factors, like advanced age, more than 65, we used to use the curb 65 earlier for assessing the severity of the infection. But even in places where lab tests are not available, the CRB65, which looks at confusion, respiratory rate, blood pressure, and age, is also a very helpful indicator for us to understand the severity. In your set, in the typical setup in our hospitals, I would sit in a clinic or in a city, I would still be using the CRB65 as a good score to help me decide whether this patient has infection which is severe or which can be treated even as an inpatient, needs treatment as an inpatient or as an outpatient. Besides the CRB65, are there any other parameters that you keep in mind, Pavitra, when you have to advise admission for your patients? Because I do understand the context of practice is different. Your patients travel long distances, and I'm not very happy if you advise them inpatient care. So how do you negotiate the decision of inpatient versus outpatient care?
That's a great question, Rajani, and these are the dilemmas that we often face, right? I mean, if somebody is traveling from 60 kilometers and has no attendant, or an attendant who is not capable of taking the person to the next level of referral hospital, and the person comes with confusion and pneumonia, you can't say that, you just move and go to the next level. And even if you do, you know that they're likely to go back home rather than go to the next level. So there are a few things, but you do need, at times you do need referral, and therefore you need to be absolutely clear if you manage it where you are. So there are a few things that helps. One is that we look at the CRB score not only at the time of presentation but after stabilizing. For example, if the blood pressure is low, and you realize that it is hypovolemic, you correct that, and if the blood pressure comes back to normal and the confusion also disappears, respiratory rate slows down, then you reassess and then decide rather than deciding right away. Right? So you do try to stabilize. If there is hypoxemia, which gets corrected by either oxygen, or in addition, if there is bronchoconstriction, clearly there is audible wheeze, or there is you find out there is wheeze on auscultation, and it is probably there is an underlying chronic lung disease. You nebulize and then reassess. So if the respiratory rate falls down, if the oxygen saturation improves, the blood pressure comes back to normal, then you are more confident that you can manage the person here. You would still classify them as severe, but it could still be managed with antibiotics and supportive care at a primary care setting. As you said, life has become easier after COVID for two things. One is, of course, pulse oximetry helps you decide in many of these cases that if oxygen levels start improving after giving oxygen and the nebulization and the first shot of antibiotics, it really helps you objectively determining whether the person can be managed in a primary care setting or not. The other is, of course, just the sheer availability of oxygen per se, right? I mean, there are times when oxygen availability in primary care setting could not be assured because of lack of oxygen cylinders, or even if you had them, to get them refilled. So, but for last 4 or 5 years, we now have almost 4 years now that we have oxygen concentrators, and that helps tremendously in making us much more comfortable in managing people with pneumonias or acute exacerbation of chronic lung disease in the primary care setting. So those few things, I think, if we are able to one, reassess after stabilizing, and secondly, I think if there is an underlying lung disease and bronchoconstriction is adding to the tachypnea and to confusion and hypoxemia, that can you reassess after that, you then decide whether to refer.
Great points that you bring up, Pavitra, that, it is important to do a good initial examination along with the history, and then also look at what you can do to immediately stabilize the patient and not keep it as one static score of the CRB-65, which helps us in determining whether the patient can be treated safely as an outpatient or would require inpatient care. In some of our patients, we could help in stabilizing them, and while they may require inpatient care for a little while, maybe the severity isn't as bad as initial if we act fast. You brought up another great point, which is about the early initiation of antibiotics. And across the country, we are facing this huge challenge of antimicrobial resistance rising. And it really is incumbent on us as the first contact for the patient with an infection to make the right choice of antibiotics. And I think along with all of us at CSA, and I know that all of your doctors at BHS take antimicrobial stewardship and your role in that very seriously. I have seen a lot of problems arising from confusions about what is the appropriate antibiotic to use. Very often people start higher levels of antibiotics or inappropriate antibiotics just based on the fact that the severity of illness seems more. And of course, we know that's not the right thing to do. We can still follow the guidelines in terms of the appropriate antimicrobial use for community acquired pneumonia, whether it is the outpatient or the inpatient. And even in the inpatient, if it is in the ICU or a non-ICU setting, the initial antibiotics that one needs to start do not include the high-level antibiotics that very often people start for more severe illness, more hypoxic patients. Just what are your thoughts about this, Pavitra, and what are the typical choices that you make in this for an outpatient treatment of a pneumonia, for example? Given the context, of course, then you mentioned that the local context is so important, that you have patients with tuberculosis or suspected tuberculosis coming to your clinic as well.
So yeah, I think you mentioned about the high, the local context and local epidemiology being important, and tuberculosis is one big problem in the areas that we work in, and probably in similar rural underserved areas elsewhere in the country, and that kind of dictates what antibiotics you choose. The other is that need to in the settings where there may be borderline patients who would ideally would require an inpatient care, but you need to treat in an outpatient basis because there is no other choice. and how do you ensure that the antibiotic cover is reasonable to cover the probable organisms. So I think a good, as I said, that I'm going back to that, a good clinical examination, both to establish the diagnosis as well as to rule out other comorbidities. For example, underlying chronic lung diseases I mentioned earlier, but they could also be, HIV co-infection. There could be diabetes mellitus. So, understanding that if there are other comorbidities or not. And thirdly, assessing severity. So I think three things: establishing diagnosis, ruling out comorbidities, and assessing severity. If you've done that, you're more confident about what antibiotic choice to make. Typically, in our settings, for patients who are stable otherwise, have they're hemodynamically stable, they're oriented, and they do not have comorbidities, we would start with doxycycline uh, and or amoxicillin. And usually amoxicillin typically would be in higher doses than what we would use for other infections, and those up to 1 gram, for 3 times a day, or doxycycline in the standard doses twice a day. And that if the patients are stable otherwise and have no other comorbidities. But if they have comorbidities, which is a large proportion of patients in our settings, we would then expand the cover to include amoxicillin, clavulanic acid, uh, as well as doxycycline. So it's a combination of two drugs, moxiclav and azithromycin is another one that is evidence based, that is recommended. It also covers for atypical microbacteria, but the problem is that in our setting there has been a gross excessive use of azithromycin for upper respiratory infection, many of which are also viral in nature. But because of the rampant and excessive use of azithromycin, we are not very comfortable because we have a suspicion that there is a resistance developing to azithromycin, and therefore we would rather use a combination of amoxicillin, clavulanic acid plus doxycycline for people who have comorbidities and are otherwise stable. Um, and the third category, of course, is those who are severe, who would require an inpatient. And we do, in primary care settings, admit patients for short durations, especially if they are unable to kind of be referred. Those who are either hemodynamically unstable, and as I said, but if they get stabilized after the correction, after you stabilize them. So in those cases, we would, or if there was disorientation in the beginning, which starts improving, in those cases, we would use a combination of the ceftriaxone and azithromycin to manage the severe community acquired pneumonias, to ensure the coverage of the common um, organisms. We avoid using quinolones, absolutely, because they also have an antimicrobial spectrum, and since they are given alone, they are likely to lead to resistance of Mycobacterium tuberculosis to the quinolones given as a single drug, and therefore we avoid them. Usually, we give fluoroquinolones only in cases of INH monoresistance in patients with tuberculosis, when it's proven that they're likely to be they require.
It's interesting to me, Pavitra, that our practices are quite similar in terms of the antimicrobial use that we adopt for patients with outpatients as well as inpatients. One more point that I think we've there have been it depends on the resources available, but you mentioned viral illnesses and the overuse of azithromycin for viral illnesses, which really would not require anything. Um, in a hospital like mine, I have access to testing for viral illnesses like a COVID-19 or a flu panel. Um, in a resource constrained setting, how do you tease out whether this patient could potentially be having a viral illness and may be able to avoid an antibiotic, whether there's testing available or not? What would do you have access to testing for this, and is it something that you think you need, or is it something that you go more based on what you're observing as a pattern in your clinical practice?
No, that's a great question, Rajani. Until some years ago, frankly, I mean, I think before COVID-19, we did not probably either see many patients who have suspected flu, or we did not suspect them enough, right? But after COVID-19, I think we are seeing increasing number of patients who coincide with a significant rise in people with respiratory illnesses in seasonal variations, right? So we are seeing huge seasonal variations with symptoms suggestive of flu-like illness in rural areas as well. And at the moment, we do not have a testing facility for flu, and I think there is a great need for testing of influenza virus in primary care settings. At the moment, it is expensive and out of bounds. At times when we know epidemiologically that there is an epidemic uh, uh, of influenza in the district on the areas that we work in, we would presumptively, if the patient does not improve, is otherwise stable and does not improve on antibiotics for a day or so, we would then add oseltamivir in those cases, knowing that after 3 days it's practically useless to give antivirals. But if in early enough, if there is a suspicion, that's what we do. But we are constrained by absence of a test for flu, and would be helpful. Simultaneously, I think since we're talking of diagnostics, the other while we said that for diagnosis of community acquired pneumonia per se, you do not really require an X-ray, right? But there are situations, especially when there are underlying chronic lung diseases like silicosis, which we see a lot in our areas, chronic lung diseases, and tuberculosis again being very common. So you do need an access to a quality X-ray. We are experimenting with a few X-ray devices, but I think ensuring access to chest X-ray in primary care settings is a useful thing for managing respiratory infections as well as chronic lung disease.
The challenges in depending on the resources available also bring up a greater responsibility on us to be judicious with our use of testing as well as the antibiotics and antivirals. One of the other questions, that keeps coming up amongst when we see patients refer to us from other places is about the use of steroids. And this is something that has been discussed extensively in various studies and in various forums about the utility of steroids. And despite the fact that over and over studies have shown us that steroids are not beneficial except in certain specific situations where they are indicated, one does see steroids being used early on in practice. And your thoughts about that, Pavitra, because with the Cape Cod study, we have evidence that says that in severe pneumonias, which are in the ICUs or in certain special conditions, when a patient has an underlying lung disease with an exacerbation that requires steroids, in most other situations, one does not need steroids. What has been your experience, you think, in the practice that you have seen around you, and what is the general practice in basic health services that you would recommend for people who are listening into this podcast?
So I think I agree with you, Rajani, that steroids per se have no role in community acquired pneumonias in primary care settings. The problem is that we see many people, especially those with underlying chronic lung disease, who are on steroids for longer periods, and that does predispose. Actually, it's not only not required; it can be potentially harmful because it would lower your immunity and increase your risk of repeated community acquired pneumonias. That's one kind of a significant risk, right? I mean, and we see a lot of it in patients that we receive who have been treated elsewhere and come with excessive use of steroids, and therefore a significant higher risk of acquiring pneumonia and acquiring then a more kind of a difficult bug to manage. The other is that the other is, again, as we talked of tuberculosis, right? I mean, and without ruling out tuberculosis, and use of steroids can further increase the risk of both contracting tuberculosis and expediting its kind of conversion into a more severe manifestation. So steroids in general in primary care settings, in our practice is that we don't use steroids in community acquired pneumonias at all, except for when people have chronic acute exacerbation of chronic lung diseases. with or without associated community acquired pneumonias. And in those also we're restricted to inhalational steroids and avoid using oral or parenteral steroids at all. So those would be one condition where in primary care settings we would use primarily inhalation if there is COPD and with acute exacerbation that required.
I do think that COVID-19 also brought that into sharp, focus for many of us, as we saw an overuse of steroids. The steroids were indicated for patients who had hypoxia, but very often we saw steroids being prescribed to patients even when when it was not indicated. And one can assume that or infer that the excessive use of steroids did lead to increased severity, the fungal infections that we saw in India, which were not witnessed in other parts of the world to the same degree. And I do hope that most practitioners understand that steroids are those drugs which are very, very useful in severe pneumonia, who are very hypoxic, requiring intensive care. But in other areas, when they are not indicated, their use can be potentially harmful. Hopefully, the lessons learned from COVID-19 and the rise of fungal infections will also remain in our minds as we treat the more common community acquired pneumonias that we see in our day-to-day practice. Another problem that we face, and I'm pretty sure you face similar problems, is the duration of treatment. For how long do we continue the antibiotics?
So in our practice, as I said, the patients, these are populations which are sparsely populated. There are distances that people have to traverse, and it's not always easy to follow up. Or either for us to follow up, or for the person, for the patient to come back in 24 to 48 hours to have a another examination. In general, we would prescribe antibiotics to stable patients for 5 to 7 days and ask them to come the subsequent week. It's easier for them to remember if you say that today's Tuesday and you come back on Monday or Tuesday again. And so usually the duration will be 5 to 7 days. But with the counseling, that if the fever or the does not subside, or if the symptoms worsen even after 2 days of antibiotics, or if any of those danger signs like confusion, etc., comes, then you report back. So that is helpful. So in general, we would and on the next visit, 5 to 7 days later, we would review that how long has the patient been, the fever has subsided or has been stable. Otherwise, the cough has decreased. So depending on that clinical, we would stop it at between 5 to 7 days usually. Sometimes the exceptions that we have, for the longer duration of antibiotics that we've seen, in a few cases where we suspected in radiological suspicion, in those cases where they came back with an X-ray, because we were also suspecting either an associated tuberculosis or something, was conditions where there was a lung abscess which required significantly longer duration of antibiotics. But in simple community acquired pneumonias, it would be 5 to 7 days.
Even with admitted patients, there's more recent studies of patients who have more severe community acquired pneumonia and require injectable beta lactams. There are studies which show that you don't necessarily need to continue the injectable antibiotic for 5 to 7 days. That 3 days is non-inferior to 7 days of the injectable beta lactam as well. And I think sometimes that helps us in being able to facilitate the discharge of the patient if they have completed 3 days of the injectable, and I'm then thinking that they are now clinically stable, and they're able to discharge. It's I think the situation is the same whether one is in a city or one is in a rural setting, that patients always like to get home soon enough, back to their home environment where they can recover better. What are the challenges and things that come up in your discussions with your patients if you have to convince them to stay admitted and patient? And how many days would you like, or what would you like to see before you say that the patient is ready for discharge home?
So in general, as I said, that in our settings, we would admit patients only if for those with severe pneumonias, only if they have no other option, or if they improve after initial stabilization. So in those patients, we would usually keep the patient for 2 to 3 days, and without knowing this evidence that you referred to, we generally practice is to give injectable antibiotics for 3 days, and then continue with the oral antibiotics for another 4 to 5 days, and review after a week. So that has been so the challenge, of course, is I think in primary care settings is of of people's ability to move to the next level of care, and that's why it is so important to uh, you know uh, being able to manage it unless it is absolutely essential if the patient requires an intensive care. And so though that remains a significant challenge in these settings. The other is that if you require if there are comorbidities, and managing that along with managing pneumonias, for example, an acute exacerbation of a chronic lung disease would require nebulization, and you know managing that as well over next few days. Earlier, there was an issue of if the patient did require oxygenation, to have that, and even for nebulization, you require uninterrupted electricity. But those are the things that we have sorted out in our clinics, at least, where there is an uninterrupted power supply that ensures that nebulization can be done round the clock without a problem, and with oxygen concentrators also being driven by power to. So those are the things that we have sorted out. But in primary care settings, those are other issues that you need to monitor. And finally, I think importantly, the ability to monitor them on a regular basis, reviewing their status, because in primary care settings, there is always a shortage. In our cases, there are 3 nurses who are round the clock available. But in these cases where you need to monitor them more closely, and that becomes sometimes a burden on the staff as well, to manage, if it is more than a few days at a stretch.
Yeah. And I do think the other part of it is making it, once you have a family caregiver who is also possibly can be trained to monitor and assess and give us feedback, as long as the patient is able to eat and mobilize themselves a little bit, and they're assured that the worry that got us to have them admitted, the confusion, the rapid respiratory rate, and the hemodynamic instability has all resolved. That then allows us to make those decisions for safe discharges much more comfortably. Do you sometimes find patients coming to you, Pavitra, with situations where they might have seen somebody else or been started on inappropriate antibiotics, let's put it like that, and you find that it is your opportunity here and now to be that person who helps to de-escalate and make sure that the patient is on appropriate antibiotics? Does that happen in your practice at times when patients might have visited somebody else and then come up with something like that?
So it does happen often, Rajani, that they would have probably come with, for example, an anti-pseudomonal antibiotic for a community acquired pneumonia. It's not unusual, and we would then ship them to our protocol. And yeah, in our cases, it's probably unlike in cities. They would not argue about it so much, because for them. But in city, I've heard from my colleagues that there is a greater effort to convince them about any change in treatment protocol or something. Here, it's not so difficult, but we in general do educate people about the need for antibiotic stewardship.
I think that is, as you said rightly, it is important for us to continuously, challenge ourselves to educate our patients better about why. Yeah, that is sometimes a challenge that we find, that, having to convince them that your disease, your infection can be controlled well with these antibiotics. And while it is essential to give you antibiotics, it's also essential to give you the right antibiotics so that we do not worsen the existing problem of antimicrobial resistance in the community. Any other interesting cases that you would have to share, Pavitra?
I think one of the greater difficulties for us is not so much in changing antibiotic, but there is a huge demand for injectables, right? So even for a community acquired pneumonia that could be treated with oral antibiotic, people would expect an injectable, and it's not their problem, because over years they've been told, and it's what I call as a supply-induced demand, that injectables are more potent than oral antibiotics, and we need to really counsel them to say that, injectables would be required only if you can't, absorb it orally, or if you're vomiting, or if you're hemodynamically unstable. And that remains a challenge. I would not say that we have overcome it, but we continuously continue to educate people about the potential harm of injectable antibiotics, including the costs, and why oral antibiotics are as good as injectable when they are not required, and there are very specific indications only for injectable. Um, so some interesting cases that you asked for, I think, as I said, that we see a lot of underlying chronic lung disease of COPD and silicosis. Tuberculosis always is a challenge. And I can remember a few patients who did not improve after the standard dose of antibiotics, and clinically did not improve clinically, though and there was clearly, it seemed, a cavity or a consolidation underneath on a clinical examination. And subsequently, when we did get a chest X-ray done, it suggested a lung abscess. And subsequently, so we continued with oral antibiotics for a longer period of time. Finally, were able to get a CT done after a couple of weeks, and that confirmed. And then, on follow up, the patient, the lung abscess was completely resolved, because and I think that is where the follow up is important. While most community acquired pneumonias would improve with the first line antibiotic, there would be cases where either because they have received antibiotics elsewhere, or because of undernutrition or reduced immunity, may not have frank signs of you know uh, of things like a lung abscess. The other interesting and difficult one has been where so because of tuberculosis, there's also a lot of post-tuberculosis lung disease, right? I mean, because the lungs are damaged, and that is where you're again have a higher chance of contracting something we have not talked much, is a fungal, the especially aspergillosis following, and there have been at least 2-3 incidents where we suspected based on radiological findings and not improving on antibiotics, and shifted to managing them as fungal, as aspergillosis, and with significant improvement in resolution of radiological findings as well. So that's where I think the ability to move on to next level of investigations when required. But I would say that in more than 90% of cases, the standard protocols followed with close monitoring and follow up at regular intervals helps in you know both
Yeah,
ensuring the.
that's such an important point that you brought up, Pavitra. Yeah, about the response to treatment. The community acquired pneumonia will typically respond to the standard treatment in 5 to 7 days, and on a follow up visit, we are looking for seeing resolution of symptoms. And sometimes it's more than that first 7 day follow up. Having them follow up again after a couple of weeks or at a month, or if there are persistent and recurrent symptoms, that is what alerts us to the possibility of something else that might be lurking, and then have us pursue further radiological testing or microbiological testing. More and more, we are able to show to our trainees and to the doctors who work with us that sticking to the guidelines really is beneficial for the patients. And all the points that you brought up, no, about appropriate escalating to when one needs further radiological testing, or harboring that suspicion of what might be there if your patient isn't getting better, whether there's underlying tuberculosis, whether there's an abscess, or whether there is fungal infection, or other entities that need to be treated. The challenges of diagnosing and treatment community acquired pneumonia remain. I think one of the other challenges that we face sometimes is that patients don't always present in the most classical manner, as we discussed earlier. If I have elderly patients, they are not able to cough. Maybe their cough is weaker than it should be. And the confusion and fever and fast respiratory rate is the only thing that will help me come to that diagnosis. And then a very focused clinical examination. So being aware of that in elderly people, a pneumonia may present just with fever and confusion, is something to keep in mind. And confusion is not something that people consider often as a sign of pneumonia or in the elderly, but it is one that comes up pretty often in our practice. And this is something that I've seen a few times, that a patient will come to the emergency room and it's on auscultation. I'm quite aware that this is a pneumonia that I'm dealing with, and I'll speak to the family member and say that, I think he has a pneumonia. I would like to get an X-ray and I would like to have this patient admitted to treat for this. And they'd be like, well, he's not coughing at all. He has no breathing difficulty and he's not coughing, but he's febrile and he is confused. So sometimes it's not that every patient will present with all the symptoms. And I think we need to keep a further margin of suspicion with the elderly patients specifically.
I fully agree with you, and also elderly, and often in our setting they're also malnourished, and therefore the ability to cough and to respond as fever may be further reduced. Yeah, so talking of the diagnostic difficulties, one of the challenges that we've seen a couple of times is missing an underlying rheumatic heart disease with mitral stenosis, which mimics acute community acquired pneumonias, because the patient comes with fever, with cough, and breathlessness, and sometimes also hemoptysis, and you suspect that it could be pneumonia. And on auscultation, if you miss auscultating the heart, you just hear crepitations because of the pulmonary edema there, and that so we've seen that in a couple of cases where it was missed, but on a careful auscultation of the heart and then taking a more detailed history of the duration of the illness and other symptoms, one comes back, and so it is important to, going back to my earlier kind of point of doing a very careful clinical examination, because that's all you have there. In a city hospital, at a slightest suspicion, you can go and do an echo or do an X-ray or run a CT, which again, even there, I think there is no substitute to a good clinical examination. And in settings where there is, relatively lesser access to diagnosis, it's even more important to do that.
One of the things that one of my pulmonary and critical care professors used to warn us about was beware of being the single organ doctor. And I think I hold that advice very dearly to my heart. My primary identity remains a physician first, before being a specialist or trained in any other subspecialist discipline. So absolutely essential to do a comprehensive physical exam, because we will pick up on little things which can matter so much in making sure that the patient's care is appropriate and a safe discharge, most importantly, restoring them to health. You might have more than one condition. One more little thing that I know is harder to accept in rural settings because of the cost factor is vaccinations. And I will admit that this is a challenge for me in urban settings as well. We know that there is vaccination that's available for adults. For the pneumococcal vaccine is available. The influenza vaccine is available. And my hope is that with COVID-19 vaccination having become so acceptable for everyone across the country, we will get greater traction amongst our patients to accept influenza vaccines and pneumococcal vaccines. Cost remains a problem, and I can understand that that would be a bigger challenge in the rural setup. But we can do our best to propagate and build awareness around it. It's been fabulous chatting with you, Pavitra, about seeing how the similarities and differences are in our approach to community-acquired pneumonia. And from what I gather from our conversation is that fundamentally the approach remains the same. It is about judicious use of the resources that are available to us. And I think the biggest challenge remains with the diagnostic resources in terms of radiology and microbiology, because the basic blood tests are available, are not as difficult to avail of, but radiology and microbiology remain challenges. And more importantly, I think wherever a young practitioner is in a rural setup or in an urban setup, antimicrobial stewardship is something that we must take as our campaign and our cause that we work towards while we are taking care of our patients. We'd love to ask you if you have any other practical pointers for young practitioners who are listening in on our podcast about community-acquired pneumonia.
So I think I'll go back to a few basics. One, I think good, careful clinical examination is and a history. There is no substitute to it wherever you are. The second is that oftentimes, the investigations are not so important in making a diagnosis or in assessing or in managing the person as we often think, right? It's with the using evidence-based guidelines, standardized protocols are extremely important in all settings. And in primary care settings, even more, because you are very clear that which are the ones that you can manage, where do you need to refer. The third is to, I think, keep looking at ways to ensure this balance between the need to refer and the need to manage, because from looking at it from a person's perspective, from a patient's perspective, moving to a next level of care is never easy. At the same time, if you over keep the patient in a setting where where the person really requires an intensive care, and therefore using standardized guidelines as well as developing a greater clinical acumen is extremely important to manage community acquired pneumonias and more when you're working in primary care settings. So don't lose sight of your evidence and build your experience around that.
Thanks so much, Pavitra. Our community science alliances clinical care pathways have been developed keeping in mind the evidence that's available, along with practical, useful pointers on using that evidence to guide our clinical care with experts like yourself, Pavitra, at Basic Health Services. And we hope that that will be something that will help young practitioners to be able to access that evidence and practice pointers at their fingertips in future conversations as well. With this, we bring our podcast on community acquired pneumonia to a close. Thank you so much, Pavitra. To our
Thanks
listeners
so
here,
much.
we will be bringing up more such discussions with experts like Pavitra. So until then, stay informed, stay vigilant, keep making a difference. Thank you for joining CSA.
This is the CSA podcast, presented by Social Alpha, supported by Blockchain for Impact.